So our first speaker today is Dr. Kenneth Rand, who is a professor of pathology and medicine at the University of Florida, Shands Healthcare System. He is a longtime collaborator with BioFire. I think he's been working with us since, gosh, before we even launched our first FilmArray products. And he's going to be talking to us about the gastrointestinal PCR panel and how it has improved both patient outcomes and clinical management and lowered clinical or healthcare costs. So we'll have Dr. Rand talk, and then I'll introduce our second speaker, Dr. Rand.
Thank you, Wade. Obviously, the microphone is on, so I'm going to be talking about our experience with the GI panel, and I have to thank our team. We had a fairly large group, but the key people were Dr. Stacy Beal and Liz Tremblay, who really did the bulk of the data analysis and also really made the study happen. We couldn't have done it without BioFire support, so thank you. There were many people involved from the company, and we certainly appreciate them. Full disclosure, we do have obviously grants, and obviously I'm speaking for in conjunction with them. So, but nothing else to disclose. So basically, conventional stool cultures, everybody knows, take a long time. They take a few days, maybe 2 or 3 days before you can be sure they're negative. And by that time, many patients are better or well, or the data become irrelevant. And if you're getting a stool culture, there may be multiple other causes of diarrhea, and you have to do a lot of additional testing to find that out. So we hypothesized that the GI panel would shortcut those clinical problems and by getting answers quicker, lead to better patient care as measured by length of stay and some of the other variables that I'll cover. Well, I may cover them if the batteries, there we go. Okay, so I'm sure everybody knows all the organisms that are on here. We'll be giving a test to you on your way out. But the key issues is that the panel picks up all the common bacteria, it picks up the common parasites and the viruses that many places would not test for, or if they did test individually, would really get expensive if you tried to test for them all. And certainly the toxigenic E. coli's. I mean, I had to look these things up to understand them and know what they even were when we got involved with this kind of testing. Surprisingly, I haven't had a single question from a clinician. So I think they all pretend they know what EPEC is, but anyway. So our procedure for this was that when a stool culture was ordered, conventionally, and I guess you can see this, which was our historical controls, that culture was ordered and reported in EPIC. And the change we made for the study was that when a stool culture was ordered, we did a BioFire panel, a GI panel, along with the culture, and then reported those results in EPIC. So because of staffing issues, we couldn't do this 24/7. So we had to run the panel only on the day shift during the week, sort of a banker's hours panel maybe. But so it took us a year to do the study, and well, I guess this guy was right about the, well, maybe not. Anyway, oh, I got it. Okay, so we'll use the pointer that works. Thank you. Our historical control group was 6 months, and our study period was a year, but we just had to do it that way to get sufficient patients in the study. So physicians ordered a stool culture. They got both a stool culture and a GI panel, and we compared to a historical control group. And as you might imagine, many of them figured this out very quickly. And when they really wanted to know what was going on with a patient, they got a stool culture, whether they thought the patient needed it or not. We had them calling up, pleading with us to do stool cultures in order to get the BioFire panel. And so that, I don't know whether that biased the results or not. I don't think so, but it was sort of an unintended consequence. So what we measured then was length of stay, whether additional stool tests were ordered on the group that got both. Because they didn't know they were getting the panel, they would go ahead and order ancillary stool testing. We looked at days on antibiotics, and we looked at imaging studies to see if there was any effect there. And basically, the panel, of course, as you would expect and probably have seen in other studies, was positive in about 30%, and this is excluding C. difficile. So C. difficile is on the panel. We did not report C. diff, and we didn't include it in these numbers. Conventional testing was positive for stool cultures, about 7%, and this was true for adults as well as pediatrics. And this just shows the whole onslaught of microorganisms detected by the patients that got the panel. And as you can see, the big three, as they have been reported in pretty much all studies, are going to be enteropathogenic E. coli, norovirus, and rotavirus, with salmonella and sapovirus sort of runners-up, if you will. And then the tail distribution of everything under the sun. Okay, so if you just focus on this column right here, this is the results of conventional testing compared to the panel testing for the group that got both. And basically, the conventional method was pretty good for salmonella. We had, a credit to our micro lab. And so we did okay on the bacterial pathogens, although there was more Campylobacter detected by the panel. And then the other ones that were not detected, were detected by the panel, were basically the ones we don't test for routinely, so they were missed, as you would expect. And I'm not going to dwell on this, but this is the breakdown of the panel versus the historical controls. And as you can see, the bottom line, of course, is on top, but that shows the original figure of about 33% positive by the panel versus 7% by conventional methods. And if you look at it by age group, the slide is a little confusing even to me, but the bottom, I'm sorry, back up. Mixed infections are a way of life when you deal with multiplex panels. So you'll see this in the respiratory panels, no matter who the manufacturer is. You'll see it in the GI panel, of course. And we had about 18% in the pediatric age group. I'm sorry. It was 4% in adults and 17 or 18% in pediatrics were mixed. So it's fairly common. So how did we do on outcomes, on costs? Well, additional stool tests, of course, you had to order by the conventional, for the conventional test group, they ordered a lot more tests, as you would expect, and highly significant. days on antibiotics were reduced. It's not technically statistically significant, but that's because they wouldn't let me do a one-tailed t-test. And imaging studies were also significantly reduced in the group that got the GI panel. So this is without telling the docs anything. I mean, we never announced that we were doing this study. They spontaneously didn't order those radiographic studies. The biggest result, I think, was the effect on length of stay. So for the control group, that averaged 3.9 days, and the group that got the GI panel, 3.4 days, from the time you did the test. And there was less of an effect if you looked at the whole admission, but from the time you ordered the stool test, which I think is the fairest starting point, there's a statistically significant reduction. That's supposed to say 0.04. Somebody here is very tall, or the slide is very short. All right, never mind. Okay, so if you break down and really look at the costs of these are the in-lab costs, what it would cost us to do a stool culture, and I think that's deflated personally, but there it is. That's about right for a C-Diff PCR, but we didn't include that. So the total cost of the additional laboratory tests that they had to do was about $36,000 divided by the patients in the control group, and you got about $60 per patient in the control group as the baseline cost. And if you looked at the radiographic studies, in the cases, there was about $12 per patient worth of cost, compared to almost 23 in the control group. And if you looked at exposure to radiation, there was, again, a significant difference. The control group got 0.21 and 0.12 millisieverts, which added up to, for the cases, an average of 1.34 millisieverts, which isn't really a great deal, but it does contribute to your long-term risk of leukemia. And the controls got more than twice what the cases got as a group. So reduced exposure to radiation. And finally, putting all of the costs together to get the bottom line, the patient length of stay savings averaged out to $400 a patient. The radiology costs saved about between $10 and $11 a patient, and the lab costs were increased because of the cost of the panel by about $117, but the net decrease, or the net patient savings, is almost $300 a patient. So, in conclusion, we had about a 33% positivity rate for the GI panel compared to 7% in our historical control group. Length of stay of our panel group was significantly reduced with significant dollar savings. And the patients who got the panel had less antibiotics, fewer radiographic studies, and fewer ancillary microbiologic tests on the stool. And although the in-lab costs were higher, the overall costs were substantially lower. And another bottom line, the techs really love this, and the docs really love it. So everybody loved getting these results and getting them sooner. Okay, well, They didn't tell me not to put a slide in for questions, but I'll skip that since we're going to do the questions later and just go to, we're not currently doing this. A lot of places are. Maybe some of you have already implemented this test. And so we have a year's worth of experience with it. We didn't run into any problems. Nobody complained about not reporting the C-Diff from it, for example. We didn't get a huge number of calls about what an E-Tech is and that sort of thing. But our plan is to restrict ordering to within 3 days of admission, unless they can call up and make a really good case. And we also plan not to allow repeat testing within a week for a negative test, and within a month, that might be a little bit much following a positive test, because they might acquire a different pathogen, so you might have to have some wiggle room there. And the issue of diarrheal stools, while important for C. diff, may not be as important for the panel. And that's because in stool cultures, the stools can be formed and you can still find the pathogens in them. So depending on the pathogen, the issues may be different from colonization that you run into with C. diff. And so this one we're going to have to deal with. And in terms of C. diff reporting, what we did do was, when we got a positive, we reported it to our infection control group. They assessed whether it made sense to put the patient in isolation. Most of the time they'd already ordered the C. diff and the positive result was known. So again, in summary, the panel performed extremely well. Look forward to your questions at the Chuck Jones Gallery. Thank you.